Hello, everybody. Good morning or good afternoon, depending on where you're joining us from today. It's so great to see you. My name is Rebecca Andrade, and I am the Educational Programs Manager here at the Kansas Health Institute. And I would like to welcome you to today's webinar, Mobile Integrated Healthcare Strategic Directions. So again, thank you for creating space to join us here today. As I introduce KHI, we would love to see who else is in the room with us today. So please take a moment to hop into the chat and share your name, your organization, state, and then what brought you to today's webinar. We would love to hear, why you're interested in this topic or what you're curious to learn about. And so while you're sharing in the chat, I'll give you a little bit of information about the Kansas Health Institute, or KHI. We are a nonprofit, nonpartisan educational organization based in Topeka, Kansas. We were established in 1995 with a multi-year grant from the Kansas Health Foundation, and we are guided by the vision that Kansas will become the healthiest place to live through evidence-based and innovative strategies, policies, and practices. We work towards this vision by providing nonpartisan information, convening crucial conversations, and facilitating learning that leads to meaningful change. If you visit our website or you stop by our building, you'll see that our work involves research, evaluation, technical assistance, and policy analysis, as well as podcasts, blogs, and gatherings like today's event. So we're looking forward to a great session with you today, where we will explore and discuss the strategic direction for mobile integrated healthcare programs and policies in Region 7. First, we will review the key findings from a strategic thinking session that took place last August with 40 participants from the Region 7 states. Then we will hear from a dynamic panel of experts who will discuss key factors influencing the successful implementation of MIH programs and policies. Throughout the panel discussion, there will be opportunities for you to share your perspectives, thoughts, and questions. And then before we begin today's session, we would like to express our sincere gratitude to all the KHI team members who contributed to this work. So a big thank you to you all. And now it is my pleasure to introduce my colleague, Wyatt Beckman. Wyatt is a senior analyst here at KHI. Wyatt will begin by setting the stage with an informational presentation and will then moderate a really great panel discussion. So over to you, Wyatt.
Thank you, Rebecca, and thank you all for joining. I'm really excited to be here with you all, and for this event. This is really meaningful work to me, and I'm so grateful you all made the time to be with us today. So, for my entire life, I have grown up in a home with an EMT. One of my parents, her name is Kathy, has been an EMT and a director of EMS in my small hometown for as long as I can remember. That meant that at nearly any hour of the day, often at the most inconvenient times, like right when we're sitting down for a Thanksgiving meal or on the way to an event, the pager would go off. She would drop everything and bolt out the door. Like all EMTs, paramedics, people that are involved in emergency response, she'd do everything she could to meet the patient's needs and address that emergency. But in many cases, the situation she would respond to isn't and wasn't a genuine emergency. The patient needed support, they needed some care, they needed some help, but they didn't need to be transported to an emergency room. And sometimes the thing that led to the 911 call, a fall hazard in the home, some wound management, mismanagement, some nutrition gaps, were things that could have been prevented with the right care and support at the right time and the right place. And when the patient doesn't need to be transported, even if she's been at the scene for a long time and spends hours doing follow-up phone calls, if there's no transport, she doesn't get reimbursed. Now, this situation is not unique to my family and to Kathy. It's not unique to rural EMS. It's not even unique to Kansas. In communities and states across the US, leaders are starting to ask and think about these situations and whether there could be a model of care that addresses some of those challenges and better leverages the skills and expertise and knowledge of professionals like Kathy, that provides the right services, that prevents emergencies and increases patient outcomes. And generally speaking, that model of care is called mobile integrated healthcare, or MIH. Now, in practice, MIH can be defined many different ways. The definition you see is from the National Association of Mobile Integrated Healthcare Providers. It can take many forms, but often it's leveraging the skills and expertise of healthcare professionals, often EMTs, paramedics, related professionals, to provide non-emergency and preventative services in a patient's home. And it includes things like providing referrals and doing coordination services. And it involves an interdisciplinary team that's patient-based and patient-centered. It's related to another term that you may have heard called community paramedicine. Community paramedicine fits within the broader model of mobile integrated healthcare, or MIH, and specifically leverages appropriately trained EMS professionals and clinicians in an expanded role. Now, these two terms are often used so interchangeably or together that sometimes you'll hear MIHCP to talk about both of them together. And that's what we're gonna spend time talking about today is MIH and community paramedicine, and across all of the various ways that MIH can take shape that you'll hear about today, all the factors, all the challenges and opportunities. At its core, MIH seeks to provide the right care, which is often preventative services that can be done by properly trained EMS or paramedic professionals at the right time, often before an emergency takes place, at the right place, which is often in a person's home, not in an emergency department or in a hospital. So let's set the stage for some background on these services. So what are some common goals? They can look a lot of different ways, but across MIH programs, community paramedicine programs, these are some common goals. Prevent hospital readmissions, expand access to care, manage chronic diseases. Can we have someone show up before that mismanagement happens and prevent that 911 call? Or alternate destinations. Can we respond to a call and maybe the best destination for continuing that care is not the emergency department? What are some common populations? Now, this is not exhaustive, but these are common ones we see. Frequent EMS and emergency department users, those people that when the pager goes off, you hear the address and you know who it is and oftentimes what the situation is going to be because it's something that keeps reoccurring. They keep hitting the same fall hazard and needing support getting back up. Another common priority population are those managing chronic diseases. So they have some care, receive care in a hospital or some other manner, and they're at home managing that chronic disease. So what are some of the services that you could see in an MIH or community paramedicine program? Again, this is not an exhaustive list, but this gives you a sense of some of the common services that are being provided. In addition to all of these, they also provide referrals, connect with other services, do some of that care management and navigation, and oftentimes do that right there with the patient in their home. So what do we know about effectiveness and outcomes for these types of services? Unfortunately, this is still a developing field of research. It's an area that the data and the evidence is still growing because it's still a relatively newer model of care that isn't as widespread as some other models of care. But there are some key areas of promise, including emergency department utilization, reducing readmissions, patients being satisfied and engaged in their care, and some cost savings. And when we look to some local programs in our region that have collected some of their own data, we see some promising, encouraging results. Wyco Care Connection, which is a program in Wyandotte County in Kansas City, Kansas. Their data, they found a 57% reduction in emergency department transports. Justin Duncan and his team, who you'll hear from later today on the panel, some of his data, he's seen over 50% reduction in Medicare claims. So with that background, I'm going to move us into thinking about and sharing what we heard from our strategic thinking session that we held last August. So we pulled together, as Rebecca mentioned, around 40 people that gathered together in Kansas City, Missouri for a strategic thinking session around MIH. Participants came from each of the 4 states within Region 7, Iowa, Kansas, Missouri, and Nebraska, as well as some national and regional partners. They represented state associations, foundations, state health departments, and lots of other groups that are involved in shaping policies and the system that provides healthcare in our region. It was a really engaging session. We had nearly 100 pages of notes, feedback, ideas. You can see some of the activities that participants were engaged in on screen. Today, I'm going to share some of the key insights from the session, and these are summarized in a write-up that you'll have access to in the resource guide that we share later on today. So based on participant feedback that we heard directly from those in our region doing this work, the growth, sustainability, and effectiveness of MIH in our region and likely outside of our region is going to be shaped by lots of things. But across all those various factors and challenges and opportunities, we identified 5 things, 2 cross-cutting factors and 3 topical factors that stood out as key areas of focus that our region, that leaders and decision makers could think about as we look to move MIH forward and consider how it could increase access to care and serve our region. So I'm going to walk through those 5 factors, starting with the outside. So the first one, point 2, is workforce. So the success of MIH programs relies on the availability and the skills of a trained workforce, oftentimes EMTs and paramedics, who are well equipped to provide these services, that have that trust with the patients and that have the support they need to feel prepared and manage that care. One challenge that came up in discussing workforce, particularly for our rural areas, is that many existing EMS agencies rely on a majority volunteer workforce. So there's concern that adding a new program may overextend or be a challenge for that already stretched workforce. That there's broader challenges already in getting professionals into this area of work. Some other things that came up in talking about workforce is that, generally speaking, this is a workforce that is well suited to provide these services with that right training and support. They have existing trust oftentimes, and they have skills. In many cases, they're already doing some of what falls into MIH. There is a key area of focus for how we train and credential or certify the professionals that provide these services. And that gets into areas of standardization that we're going to talk about later. Scope of work provides the foundation and bounds for what services can be provided by these professionals. And in a lot of cases, many states have not clearly defined that scope of work. And a final point in this area goes back to that workload management and sustainability. That we want professionals to come into this field of EMS and paramedic, and this MIH allows them to provide more services, but does not overextend them and can actually support sustainability of that service. The next area I want to talk about is funding. Across the session, participants identified sustainable funding as a key factor every time. In every discussion, it came up as a key factor that will shape the continued development and growth of these programs. Many MIH programs, even those that are currently running, face challenges in securing long-term financial support. There are inconsistent funding streams, limited reimbursement opportunities, particularly for situations where there isn't transportation. Part of the conversation in this area talked about the range of funding sources from self-funding to grants and pilots, all the way to reimbursement at the private or public level, Medicaid or things like that. The last area that came up across all of our conversations was data. An effective system for data gathering and sharing was seen as crucial to both sustain and support long-term investment and growth of MIH programs. For many services, data is not really uh, able to be shared easily with their partners. There's not that interoperability. And sharing across jurisdictional boundaries, one county to another or across state lines, was also seen as a challenge. There's variations in what data is collected and the standards for that data collection. This was seen as really a key area to support that research and evaluation base, to continue to demonstrate the potential value and support policy discussions. Now I want to move us into the inside of this graphic. So what are those two cross-cutting factors that we saw? Collaboration and standardization. When we think about workforce funding and data, underneath and through conversations around those three topics are collaboration and standardization. Collaboration came up often in our discussion. MIH is inherently an interdisciplinary model. It requires effective partnerships, referral networks, connections to services at the programmatic level. There has to be good collaboration. On the systems level, the development and implementation and refinement of policies that are shaping these programs, things like credentialing, funding, that's going to require the involvement of stakeholders that are outside of emergency medicine and services. Another key aspect of collaboration is managing any unintended consequences and managing relationships with existing healthcare professionals and organizations in a community. How can we develop these programs to where it is mutually beneficial for everyone involved? To do that, we need to involve those existing healthcare partners in the conversation. And that has to extend to things like social services, nonprofits, behavioral health, substance use. And we need local input to guide the development of these programs to where they can be tailored to meet the needs of a community. The other cross-cutting factor that stood out in our conversation, standardization. So standardization, the act of setting clear definitions, clear boundaries, clear requirements for things like education, scopes of work, services, financing. This was seen as something that could support greater sustainability for these programs moving forward. It was also seen, however, as something that could introduce some challenges if it limits an ability for a program to be tailored to specific contexts and specific needs. So there's this balance between room for flexibility and variation, which currently MIH programs have a lot of that, generally speaking, and creating more standardization that maybe with more standardization to the right level could support some of the other policy changes around funding, data collection, and workforce to grow and sustain MIH programs moving forward. So when we back up and zoom out, again, these 5 areas are things we're going to continue to talk about and think about as we consider how MIH programs are working now and how they could be supported moving forward. And the great list of panelists that we have coming up here soon are going to dive into some of these areas more. Another thing we did in our session was we pulled out and identified some of those key strategies that we heard across the session about ways that we could move MIH forward. And I'm going to share those 4 strategy areas with you now. The first was setting up, establishing, supporting more collaboratives and coalitions that can drive that cross-sector collaboration and engagement. This was seen as a way that could also create a collective voice in the policymaking arena. So if there's a coalition, a multi-county, multi-state, regional coalition and collaborative that can collectively engage in the policy discussions at the state, regional, and federal level about those key areas like how MIH services and scopes are defined, funding policies, and things like that. Another potential value of collaborative and coalition is that those coalitions, those collaboratives can provide technical assistance and support at the local level for those looking to start and explore these programs. The next strategy area that was heard is enhancing data collection and sharing. A specific thing that was mentioned was a regional approach. Could there be regional data sharing and some more consistency about what data is collected? It was brought up that this enhancing data collection and sharing could support partnership development. It could provide the data that's needed to design mutually beneficial programs and demonstrate that impact. There's also points made to be intentional about leveraging the existing data that is collected, whether that's an EMS agency that already collects data, hospitals that have data for that patient, or other data sources. And finally, enhancing data collection and sharing can support evaluation and drive investment and policy change. Oftentimes, when going to those conversations, we can say, how do we know that this has a return on investment, that this is worth trying? That data can answer whether that proof of concept and value is there. The next strategy area, establishing training programs and credentialing pathways. This can increase the number of trained skilled professionals, and creating clearer standards for education, curriculum, testing, credentialing, and scope of practice could support some legitimacy for the program area, and it may help further conversations about reimbursement and financial sustainability, because there's greater clarity as to who is providing these services and what those services are. There was a point that these programs could be integrated into existing training opportunities. So places and colleges and programs where we're already training EMTs or paramedics that can add this on and extend that skill range. Finally, this could also connect and create a broader on-ramp, a broader career pathway range of opportunities for those that are interested in healthcare. The final strategy area, sustainable funding models. This was identified as the most common weakness for MIH programs. It was pointed out that pilots and grant funding can be a really important catalyst for developing and testing these programs. They can go long ways to building that evidence base for that buy-in and sustainable reimbursement. There's a point that reimbursement, as it's explored and policy change looks into that it would be valuable to establish reimbursement for a wide range of services. In the conversations around reimbursement, there's opportunities to engage both Medicaid and private insurers, as well as exploring opportunities for state plan amendments and other federal cost sharing efforts. So with that background, I want to now transition to our panel discussion, where you'll get to hear from those doing this work in different settings. And as we get ready to dive into that panel discussion, and I get ready to introduce those folks, I want to point out that you all will have in chat a resource guide that's going to be dropped. And that resource guide that Lindsay just shared in chat will do a couple different things. The front page is going to give you easy access to a bunch of different resources that we think could be valuable for you to continue exploring what we've learned about MIH programs. It includes a direct link to the summary of the strategic thinking session. And when the recording is available, you'll be able to click there and go to that recording. On the back page, it has some space for you to take notes, jot down some ideas as we engage in this panel discussion. So with that, I'm going to now introduce our panelists. So our three panelists today are Chrissy Bartell, Justin Duncan, and David Jordan. Chrissy Bartell is paramedic and director at the Norwich uh, Ambulance Service in Kansas, a small ambulance service. And she's also president of the Kansas EMS Association, or KEMSA. Uh, she wears many hats. She's actually in Topeka, the state capital, today because she's coming from a KEMSA meeting that she's involved in. Chrissy has a ton of experience in both urban and rural settings and brings that practical applied experience of running an EMS service to our panel, as well as some of that statewide engagement. We're really excited to have Chrissy join us today. Our second panelist, Justin Duncan, is president of Show Me MIH Network in Missouri. He's also CEO of the Washington County Ambulance District. Washington County Ambulance District serves a rural region in Missouri, and Justin has, I think, more credentials behind his name than just about anyone I've ever seen. He comes with so much experience and insight into this work, and he is also actively engaged in policy discussions at both the state, regional, and national level. We're excited to have Justin join us today. Our final panelist, David Jordan, is President and CEO at the United Methodist Health Ministry Funds, often known as the Health Funds. David and his team have really focused a lot on access to care in their work, and they've been a leader in exploring and supporting and considering MIH as a model of care to advance access to care in Kansas and our region. David's involved in a lot of policy discussions across the state and region as well, and brings a lot of expertise in that area, as well as the perspective of a funder that's actively working to support these models. So with those introductions, I'm going to stop sharing and move into our panel discussion. Chrissy, Justin, David, thanks again for being here. So to get us started, I want to turn to you, Justin. When we talk about MIH programs, I shared a lot about what we heard about MIH programs, some of the challenges, opportunities, but generally speaking, MIH programs build upon existing EMS laws and policies. So I think it's a valuable starting point for us to think about this conversation, to remind ourselves historically, and maybe even currently in some instances, how has EMS been seen within the broader healthcare system? So when people think about EMTs and EMS, what do they think when it comes to EMS and healthcare?
Well, I'm pretty sure any EMT or paramedic on the call has been called an ambulance driver at some point, up in potentially yesterday or today. And I think that, the policies around our business or the industry, when we talk about them at the federal level, is we are not healthcare providers in the eyes of CMS. We are a service that renders transportation. And that goes really back to the infancy, 70s, 80s, depending on, what state you were in. And we were funded to reduce deaths for highway traffic deaths. That was the original inception of a formalized EMS system. And while the cares evolved, the education standards have evolved, the faces have evolved, the technology has evolved, the policy hasn't kept up with the times. We're housed under DOT and NHTSA at the federal level. And so while we identify as healthcare providers, I would like to think that I still carry a paramedic license. Chrissy carries a paramedic license. We do a little more than just give people a ride to the hospital. However, when you look from a definition at CMS, that is not the case. And so when we talk about mobile integrated healthcare, we need to accept that EMS really lives at this intersection of healthcare, public safety, public health, but getting folks to really understand that we're not considered an essential service. So I love asking everybody when I get into a room of people, if you call 911, Do you think that you're guaranteed to get an ambulance with a trained professional to show up at your door? And everyone raises their hand, yes. But from a policy perspective, in the grand majority of the United States of America, that is not the case. So while we're not essential, we are expected. And that message really needs to be elevated. So we can't really talk about MIH or preventative care without having the baseline understanding of the emergent side of the house or the traditional side.
And yeah, really, really well said there. I think foundationally for us to engage in conversation, talk about some of these technical and policy challenges around funding and workforce and data, some of it builds on the foundational idea that our EMTs and paramedics, these people that respond to emergencies, that sometimes we think of as ambulance drivers, have the ability to provide a lot more services and already do a lot more than just transport people and just respond to an emergency. And so some of it, that's almost a necessary recognition before we move forward that baseline, a lot of EMTs and paramedics have some baseline skills that maybe we're not appreciating at the policy level. But what I've heard and what I think, Christy, I think about your role. Maybe at the policy level, there's not that recognition, but when we think about the workforce that's doing this work, my sense is that oftentimes those EMTs and paramedics that do show up are really trusted individuals in their community. And they are seen as more than ambulance drivers, even if sometimes they're called that. And Chrissy, I want you to, has that been your experience thinking about your community and the role and the trust you have built in and how that plays into setting us up to have this conversation about extending the opportunities for you to provide care?
Absolutely. In our communities that we serve, we are actually the only healthcare providers. Both of our communities do not have a hospital. There's no doctor's office. EMS is the default healthcare providers. And part of the benefit being in those small communities, we go in those homes, we have those trusted relationships built with our community members, and they rely on us for their healthcare needs. And many times we know that the 911 call may not really be the emergency, but there is no other resource for those patients, and they don't know who else to call. So their default is 911. So we go into that home and we're trying to provide assistance, recognizing that really the heart of the matter is a much bigger issue than just responding to this 911 complaint. And sometimes when we get in the home, we're finding those complaints do not really match what the needs are, and trying to find a way that we can match the needs of the patient and the resources they need. And in these especially smaller communities where it's your friends and your neighbors, people that they know well, they trust them to try to guide them to where they need to go. And so we have found that they're very open and receptive to it because we know that they need help and we're just trying to get them connected to the right resources. And I think we're at a crossroads in EMS. Are we healthcare providers? Are we first responders? Where do we land? And it's been a struggle to get us viewed as healthcare providers, particularly in payers and in policy. And while initially we were viewed as a transport model, we know that we've evolved past that model and we're providing healthcare in the homes. We're in a unique position that we are the eyes and the ears of the hospitals, the clinics, the doctors. We're going into their homes and we're meeting the patients where they're at. And that's unique because patients can go to a doctor's office and lie about if they're eating, if they have food in their home, the status of their home, what their daily life is like. And so as EMS providers, we have that unique relationship with patients that we can build upon that. We have their trust. They can be honest, or if they're not, we're in their home and we can see what is happening. And that gives us a unique perspective to make this a successful model.
Justin, I saw you on mute. Do you want to add something there? Saw lots of head nods.
I mean, well, other than preach, sister, my standard spiel is we render healthcare every single day, irregardless if the federal government wants to acknowledge it or not. We render it every day. We sometimes take people to the hospital, and folks oftentimes want to use the term first responder in your rural communities. we're the last responder, we're the last resource, right? There is no other form of healthcare in many rural communities. Carrie and I are both rural. And so they have no other option but to call 911, and we figure it out.
Yeah, David, I want to bring you in. We've got two folks that are EMTs that are doing this work. You sit in a different spot, but you sit in a spot where you're really thinking about this broader healthcare landscape, thinking about how do we sustain access to care? How do we be innovative and creative in keeping it available where it is, filling gaps where unfortunately we have a hospital close or something else. So from your spot, how do you see as sort of a starting point for this conversation? How do you see MIH fitting into this broader conversation about access to care and healthcare?
Well, first of all, I just want to say I certainly have never driven a truck. So I have the pleasure of spending the last 3 days out with Justin in Southeast Missouri, and it is amazing to see how the the EMT and emergency response for the ambulance system he runs serves the community, but the partnerships that exist are really critical to making the program successful. And those same partnerships will be really important to making sure advocacy to establish sustainable payment models are successful. Um, you know, really, and Justin and I had a good conversation about this yesterday, and I think community paramedics like CHWs are there because we have a broken system. People aren't getting the healthcare they deserve. The barriers may be geography, and transportation. The barriers may be low reimbursement rates. The barriers may be not enough providers to serve the community. And you see community paramedics filling the gap, whether or not it's a housing department in the center of town where a community paramedic has trust with the folks there. They may be doing a food drop, and they're also doing a social determinant of health screen, and then coordinating with the CHW to help the patient navigate the system. Or on Tuesday night, we were out in a rural hilly mountain community on back dirt roads, and the patients were turned off of Medicaid because these paperwork requirements that exist become a barrier to care, and people lose coverage. But who is there to fill the gaps? The community paramedics, whether or not it was to help make sure that a ramp was there so the house could be handicap accessible, or that the food drop that could occur, and then blood pressure screens can happen. So the fact that there's trust between patients and community paramedics, the trust that different services can be delivered, and health isn't just about what happens in a doctor's office, and understanding social determinants of health, and then the trust in the leadership of an organization that says we can be more than what is we're traditionally seen as providers, and we can do more for our community. So um, there's just there's just so much that goes into this, but uh, paramedics and EMTs are so well positioned with the framework of mobile integrated health and additional training as community paramedics to fill those gaps and to work in partnership with other trusted providers in the community.
Yeah, and that word you had there, partnerships, saw in chat, Sarah said partnerships with a heart. Partnerships are a really key part of an MIH program being successful and being sustainable. And it sounds like what you've seen, David, and what I hear from you, Justin and Chrissy, oftentimes MIH programs are filling gaps. They're filling a need that's already there that for a variety of reasons isn't being met. But something we did hear in our strategic thinking session was some concern or some caution potentially from some folks in the room when they hear about the potential benefits of an MIH program to reduce ER visits. Heard from one side, reduction of ER visits sounds like we're saving a visit, we're saving costs, we're doing a good thing. But from the perspective of a hospital that is maybe struggling financially, that same success can be felt differently. It might be seen as, well, that's a loss of revenue, that we depend on an ER visit to keep us afloat. So when we think about that perspective, I want to come to you, Justin. You've been doing this program for the longest time. I'm sure you've had that conversation. When you hear that question or that concern, or you're talking to that hospital administrator or the other person involved in that sort of care, what do you say? What do you say to that concern?
So I've had this conversation more times than I can count, actually, and I think it's the conversation that we have is the most important letter in MIHCP that we like to blend together is the I, and it's integration. So we're not here to replace the hospital. We're here to integrate the service model with all of our partners, whether it's an FQHC or a hospital or a public health department or a community behavioral health center, or all of the above. As you'll start learning, you just keep saying and. But when we're having those one-on-one conversations, the goal would be take patient Wyatt, who is a chronic utilizer of the emergency department because of his unmanaged diabetes, and he's a no call, no show to all of his appointments at your rural health clinic. Let's get him back on the wagon and back into primary care. So you might lose the ED visit, but let's work on getting him back into primary care. Let's work on telehealth visits with your primary care providers that you still get reimbursed for. Let's work on lab draws that come back to your facility. Let's get back him on track with his A1C checks that can come back to point of care testing to your facility. And so what we've seen in a lot of the data for our long-term patients is you see, well, yes, you'll see ED volumes go down and overall cost savings go down. You see an increase in primary care billables. There's still a net savings, but then we have to look at the quality metrics on the back end. And so is there an ACO that's involved? Are there incentive dollars that can be captured because of those quality metrics? And then I will go to my grave saying that if we're going to render primary care out of the emergency department, if that's the only way for a hospital to stay afloat, we have a big problem and we really need to address it, because that's not what's in the best interest of the patients we're called to serve. We're all healthcare providers first, right? But I know that my folks want their paychecks to clear, and I'm sure Chrissy's do too. And I've watched community hospitals close. I've also watched ambulance services close. And so I think the I and integration and working together and going at it with we're not here to replace anything. We're here to augment a system, integrate into your system. So my pitch always is, let me work on your no call, no shows. Let's just see what we can do, right? You're making $0 right now. Let's see if we can get them enrolled back into your system. Or what's your success rate on ED discharge with no provider of getting them to actually show up to your clinic? I'm going to go with it's pretty low. So why don't you give us those referrals and see how many can we convert to a primary care from your ER visit? So it's really trying to take that episodic ED visit, episodic EMS visit, and convert it to a holistic approach of integrated care for the patient.
I guess I'm happy to jump in. I think I appreciate Justin focusing on the I and the integrated, because I think the integrated approach is critical. But I also think stepping back and just focusing on health and taking care of the health of the patient, and the health of the community, and then building those collaborations locally are critical. I mean, making sure you're working with the hospital CEO to develop a vision on how everyone can be healthy, and how both patients can be healthy and the institutions can survive financially. Obviously, no margin, no mission. Then I think it's, what other community partners can be brought in and can exist that benefit all of these anchor institutions, because hospitals, clinics, ambulance services are critical to the future of rural communities and to rural communities thriving. And I think that's what everybody wants. So I think if you're looking at community partnerships, civic partnerships with the health department, with the school committee, with the city government, working with businesses in town to make sure that there's a plan, and then working with faith-based organizations. I think getting everybody on the same page, both from we're integrating care, but we have a vision for what this community looks like when it's healthy and thriving. A rising tide lifts all boats. And I think, to be successful and to really maintain thriving communities, we need to make sure that we get over some of these territorial battles and focus on like what makes the community special, and that's the health and vibrancy of the community.
I saw a question come in chat, and it's a good reminder as you're starting to hear some of this feedback and some of these ideas. Share your comments in chat. Share your questions. I'll bring those into the discussion as we go along, but encourage you to jump in chat. So thank you both for talking about how you would think about that conversation and ways to approach it. Fundamentally, it sounds like it requires a lot of collaboration, a lot of teamwork, a lot of discussions, not unilateral decisions that don't take into account different challenges, opportunities, perspectives. Something that came up that I want to shift us to, that if we at this point in thinking about MIH say, I see the potential value. I see why this could work. Why isn't it happening in more places? So what are some of the challenges and what are some of the strategies that could move us from where we're at now to supporting it in more places? And I want to start with standardization because it's sort of a cross-cutting idea that sits throughout a lot of the conversations we're going to continue to have about MIH, data, about workforce, about scope and practice, and about funding. So starting with standardization, Chrissy, I want to come to you. You work in a rural area now, but you have experience in an urban area too, and you're also president of the Kansas CMS Association. So you've seen about EMS, about emergency response, about healthcare in all sorts of settings and scenarios, different geographies. When you hear the word standardization, uh, standardizing training or certification or curriculum or scope of practice, what's your reaction? Can that be done in a way that supports sustainability, but also works just as well in Norwich as it does in Kansas City, as it does in St. Louis, as it does in Ness City?
Sure. And I think that is important to making it successful. And that's part of what some services are hesitant to implement because they don't know, where do I start? How do I do this? What does this even look like? And I think if we can standardize education, training, expectations, that also gives services a starting point of, how do I build this model? It gives them something to look at. And I liken it to EMS. While we have services that have different protocols and different operational procedures that are specific to their area and what their needs are, as a whole, we have education to become certified in EMT and a paramedic. And so our base foundation looks the same across the board, and then locally can tailor it to their needs. And I think that this is much the same. If we can have some standardization, one, it gives validity to what we're doing. We talk about that all the time, that we want to be recognized as healthcare providers. I think this is one of those steps, as when we're providing this care in the communities, that gives it that validity. It also gives us that jumping off point that our education is the same. While EMS is great at managing acute problems, our knowledge is great in emergency situations. Our knowledge of chronic health disease process and treatment is not as deep as it is as the acute setting. So this standardization and providing education would also increase our knowledge base so that we can be providing the appropriate care, building on what we already know. The foundation's there. We just need some more education so we can be appropriately managing the conditions and patients that we would run across. And I think also to the community, it speaks to some expertise in the matter. We talk about the ambulance driver title that we often get called, I think if we have some more education and initials to go behind it, that just gives us more credence and street cred, if you will, to the people that we serve, as well as on our payers and politically. It just gives more teeth to what we're doing. And so there's a standardization test that you can take. I think that having some education to kind of what does MIH look like, what does community medicine look like, and giving some educational components so people have that background to start, I think would also be very beneficial.
Thanks for that response. And there's a lot of areas standardization can be thought about. We'll talk more about data here, talk about funding, scope of practice. You pointed to education. So let's talk about education and workforce. So we have that foundational set of skills. So we can add to that with additional training, additional certification. What would some of those, and you identified some of them, but thinking more broadly, what are some of those core skills and competencies that if we're going to, at the state or regional or federal level, say, more clearly define and support this education pathway, what are some of those core skills and competencies that need to be there? And I'm looking at you, Chrissy, and Justin as ones that have been doing this work. What are some of those core skills that need to be part of it?
So I'll take the stab at it first, Chrissy, and then you can jump in here. When some states have standards, right? In Missouri, we have endorsement. We have a license endorsement that is a community paramedic, requires X amount of hours and X amount of competencies. But from the basic level, I took one of we employ nurses as well, and so I took a nurse that had started her career on the med-surg floor, went to the ER, did some other things, worked EMS as well, and I said, okay, you've now had the beauty of seeing both sides. We've made you half a paramedic, right? Now I need you to take these paramedics and make them half a floor nurse. Things that we weren't educated about: silliness, wound care, dressing changes. We on the emergent side, that's a nasty wound. We're going to cover it up. We're going to draw blood. We're going to draw cultures. We're going to draw a lactate if you meet sepsis criteria. We're going to start broad spectrum antibiotics. That's how we're trained, not what's the calorie intake to make sure that this wound can heal. I looked at wounds. One of my favorite was looking at wounds and going, wow, that looks terrible. And we're gonna Peyton's her name. She's like, well, it doesn't look that bad to me. And I was like, cool. Well, we were fundamentally educated differently, right? You're looking at long term. How do I get you back to normal and home? I'm about sepsis is going to kill you. Let's stop that first, right? And so I think when you think about fundamental skill set, we can talk wound care management, discontinuing of ports and of PICC lines. We access them all the time. We give medications through them all the time, but we don't then discontinue them and leave them at home. So it's really a combination of home health. It's a combination of med-surg nursing. It's a combination of resource navigation. We fully believe in and require our community paramedics to be community health workers so that they can understand and support resource navigation and referral system. I will also throw in that my community paramedics address more non-medical needs than they do medical needs on any given day of the week. The drawing blood is drawing blood, right? Whether it's in the back of an ambulance or for an emergency call or sitting in someone's living room. I think your education standards also, we need to set the floor, not the ceiling. Missouri doesn't have a state dictated scope of practice for a paramedic, so that's cool for us. Chrissy's got different issues in Kansas. Folks in Colorado have different standards, in Florida and California, right? So we have overall national baselines, but you have you also then have your state standards, but then you have your local control as well. I heard you say, Wyatt, thinking about St. Louis versus Wichita versus Norwich. Well, diabetics all need access to food. They need sustainable housing. They need to understand their disease process. Their challenges and their barriers might look different in Norwich versus Potosi versus St. Louis or Wichita, but their needs are the same. They just might have different, we're going to have different barriers. So I think it's important that we're setting the floor, not the ceiling, when we start talking about these things. Because Chrissy might not have a problem with diabetic high utilizers, but if she develops one in her community, let's have a baseline set and then let her adapt to the different needs. So I don't want to pigeonhole us when we start having these conversations, because one of the biggest benefits to these programs is that we can be adaptable, we can be diverse based on the needs of the community down to the individual patient.
David, jump in there.
Yeah, no, I think this is a really important discussion, and I think it's long overdue in the healthcare space, is that, just as transportation can be a barrier to getting a patient to healthcare, education that is overly onerous is a barrier to both training somebody to provide healthcare services in a competent manner, as well as keeping providers in communities. So I think we really do need to take a look, especially as there's changing demographics, changing rates of educational attainment, depopulation in rural communities. Like, what does it mean to train a healthcare team? How do you build a team? And I think there's a really strong case, and this is a perfect example of this, is moving towards more competency-based education models, where you're blending non-licensed credentialing processes together to make sure you're building providers that make sense for the populations you're serving with the backgrounds. And ultimately, you're part of a team where there is expertise, but you trust your team. And there's some great questions about community health workers, certificate trained program. I think, peer support specialists, doulas, community paramedics. I mean, there could be multiple pathways to finding that provider that fits the needs of that community, that clinic, that ambulance district. We need to find ways to encourage and incentivize this creative approach to training and building a team. And then we also need to tackle some standardization, because we recognize that's part of reimbursement and sustainable financing. But we're well past time where the way to get paid for healthcare, which is still happening, let's make sure it's a physician assistant went from an associate degree to a bachelor's degree to a master's degree, now to a PhD. It wasn't because that PhD made them a better physician assistant. It went there because they thought they needed that for the stature to get paid more. So that's going backwards in some ways. We just need to rethink, like, if I'm in a community like Norwich or Potosi or even Wichita or St. Louis, like, how do we make sure we take that kid out of high school? If they want to be a healthcare provider, it would be great if they want to be a doctor, but maybe they don't. They may want to be a CHW that then goes on to become a community paramedic and an EMT and a paramedic. So we need flexibility. It needs to be based off of competency, and we need to make sure that we find ways to pay these providers too. And I'll get off my soapbox.
No, I think you should stay on your soapbox, because without the funding models then to behind it, it all dies. And switching from reimbursement to compensation, and how do we fit into a value-based care model, right? Right care, right place, right time. Those are uncomfortable conversations to have. But at the end of the day, Chrissy wants to maintain healthcare services in her community. I want to maintain healthcare services in my community. Those are our responsibilities. The elephant in the room is there has to be an appropriate compensation methodology on the back end, or they don't exist.
There was a question in chat about CHWs being a good partner, a good relationship between MIH and CHWs. David, you touched on that some. Justin, I know you think about the collaboration, the sort of synergistic relationship between CHWs and MIH programs. Within your specific program, how do you approach CHWs?
So first, I couldn't spell CHW, let alone know what they were 5 years ago. And now I am a CHW, and I will argue I've been one for 22 years. The 22 years I've been licensed as a paramedic, we just didn't have fancy initials past our name. My office staff and my billing team have been helping folks get enrolled in Medicaid and navigate the healthcare system. Or, Chrissy, how many times do they call the building and say, "Can you come check on Ma for me?" Or, "I don't understand what these lab reports mean. Can you help us understand it?" Or, "We're trying to get a CT." So, one, our community paramedics are all required to have a CHW certification. We took that stance of we felt that was important because all of our partners employ CHWs and utilize CHWs. So we wanted to have that same level of understanding and knowledge to walk a mile in their shoes. And I'm not just talking our clinical partners. I'm talking about the community partnership. I'm talking about jail staff, about reentry council, and public housing assistance programs. So that level of importance. Our program is handled where our dispatchers in our system are all community health workers as well. So my CPs in the field have access to a community health worker in real time on the other end of the radio that's also tracking their times and their mileage and scheduling their visits. And then they do their background conversation with their CHW friends based on what the needs are. This is a healthcare patient, or excuse me, a health center patient with our FQHC at Great Minds Health Center. Ernie in my control center calls and talks to the CHW at the health center. This is an FQHC patient. Boom. They're talking to that one. We need to get together with the community partnership because they provide housing for those experiencing homelessness. So you have CHW talking to CHW so that the community paramedic can focus on the work in the living room or at the on their front porch step.
Thanks, Justin. I hear again in that we've got to have partnerships with these different entities. We've got to maintain those relationships and build upon them. I want to get us into funding and that conversation, but before I do, there's a piece of this that I feel like we need to touch on before we get into sustaining it financially, and that it's this challenge of sustaining workforce that's already there. And Chrissy, I want to come to you. We're talking about MIH, we're talking about recently CHW sort of adding these opportunities to continue to provide services, provide new services with that training, and set up financing to support that. But we know many of our especially our rural agencies, they're already struggling to maintain their workforce. Many volunteers, it falls on a handful of people that are on call almost 24/7. And you people that are doing that are brilliant and wear so many hats, but sustainably, that's a challenge. So from your perspective, when you think about MIH services, you're in the spot where you're involved in a pilot program here in the state to explore MIH services, and you're also in this smaller EMS agency. How do you think about navigating this current workforce, but exploring this new opportunity that could be really meaningful?
Right, like adding just one more hat to wear. Initially when we started looking at MIH, that was one of my concerns. Like, we are pretty maxed out. I have a volunteer service. We're a very small department, and I'm adding more to the plate. And so what does that look like? Is that something that we can accomplish and not feel so overwhelmed? And so I was very hesitant initially to try it. But when I really thought about it, a lot of what we're doing already is those very same things that we're going to do. And so when we've talked about it as our staff, as looking at it, is this something that we can take on? A couple things came to mind. One, we know that we get a lot of calls that are not emergent. at least half of our calls are not emergent. And so that leads to provider burnout and frustration, as well as utilizing resources in an inappropriate way. So we're tying them up on a non-emergence call when we are tight on staffing and resources. And if other calls come in, we have to kind of divide our resources, and it can make it challenging. So recognizing that this could fix some of those problems and make better use of our resources made sense to my volunteer staff. It also, for us, was a thing of why are people on our department doing EMS? And for the most part, it is because they want to help their community, and they view this as just another aspect that they can provide support to those people that they're already seeing. There's frustration when they're going and they recognize this isn't what this person needs, but our hands are kind of tied and we have to take them to the emergency room. So they understand that if we can add this extra layer to the services we provide, they feel accomplished that they're actually helping someone and meeting someone where they're at. So not only is it beneficial to our service and the use of our resources, it also benefits the patient actually getting what they need. And then it also provides them some satisfaction that they are making a difference in helping, which is at the heart of why many of them are helping. And then the second part of that, also recognizing that there was some funding available and hoping that we can get to some reimbursements for MIH or some ability to charge. They forecasted long term that if we can implement this now, we can start seeing some dollars coming back, and maybe that will also help the sustainability of our department. And so as a pilot program, we received grant dollars to initiate this process, and it's a 3-year grant. And so part of it was recognizing we're going to get some money back for what we're already doing every day. And so financially, it was beneficial for us as well, to sustain us into the future. And then hopefully we can secure funding beyond that 3-year point. So we viewed it as very beneficial for multiple angles. And it was you just couldn't say no to that. And it does seem daunting to take on one more task and one more hat. And that's why partnerships are important. I've been fortunate that I know a lot of smart people that are far smarter than myself, and I have those resources that I can ask. What works for you? How can we make this work? And while it may look differently in the Kansas City area or in Missouri, there's still components that maintain the same, and we're trying to achieve the same goal. And so we can reach out to those people and say, hey, you've been there, you've done that, give us some guidance, and they're happy to do that. And so it's been a great experience for us. I feel like you must have been in my county if you knew what it's like to run a small service. We're tight on staffing, but they recognize the importance of the work that this can provide.
I'll just share a story about just on the workforce front, which I was really impressed by, is we were doing this video shoot out in Washington County, which I referenced earlier, with Justin's team. And I talked with one of the growing members of the MIH team that is trying to build a program under Washington County, but in a neighboring county. And he has worked in as a paramedic his entire career, and he was probably in his mid 50s. And he said, I am so excited to become a community paramedic because I wanted to know what was next. I had been reading about community paramedicine. I wanted to do something with patients beyond just transporting them to the hospital. And this is just so innovative to be able to, find ways to help support them being healthy, and addressing these social needs. He was doing a food drop, or supervising a food drop, doing a food drop for patients. And it was just, but he recognized this was a chance for him to do something exciting with his career and serve his community in a different way, especially after he had a leg injury and tore a tendon in his leg. He could continue to serve, continue to be involved in healthcare, and it was really a new, exciting way for him to be part of a team. So I think it really does become an opportunity for even small operations.
Justin, Chrissy, I'm sure you could add to that. I'm looking at time. I see a couple questions in chat. I'm going to move us into a new topic. And thank you all for everyone that's adding questions in chat. There's one that I want to lift up to start. and it sort of connects us from two big areas that keep coming up: data and funding. So Raul asked about what critical infrastructure is missing for MIH and other collaborators to use tools to better capture that holistic health, to better capture the data. What data do we need to build that buy-in, particularly for that reimbursement conversation? So let's connect the dots from what data do we need to drive the conversation for reimbursement. And Justin, you're first, you unmuted. Kick us off.
Well, I'm a data nerd, okay? So I think Raul lifts up an amazing point in that all of us are collecting data. I don't know that we know it. And then we're all trying to reinvent the wheel. And so we kind of did a timeout and went, why aren't we doing what our rural health clinic or our health center partners are already doing? And so I saw something, in there about SDOH assessments. We've adopted the Prepare Tool assessment as a standard flow. We've adopted HEDIS measures. Why reinvent the wheel, right? Let's look at what quality metrics already exist. You have to think from a historic standpoint. If you're an EMS agency, we're housed under DOT. So our historic data metrics have been: what time did you get dispatched? What time did you get out the door? What time did you make it to the scene? What time did you take them to the hospital? What were your delays in care? And so more operationally focused data elements versus patient outcomes and clinical indicators. And so, Chrissy's point earlier was, if we want to play healthcare, we're going to have to play healthcare. And I think this goes right in line with that. My quality metrics should be the exact same expectations of a clinic. We're just rendering it in someone's living room. That's how we're going to be able to measure the ability and measure let's look at the quality metrics of my healthcare partners, brick and mortar in my community, or national averages or state averages against our MIH program, because if we want to play healthcare, we need to be held to those same standards to be able to render that level of care in their home. I think that we have done a huge lift in Missouri in trying to get some grant dollars, and then in partnerships with our friends in Kansas as well, to define that minimum data set and dangle the carrot and go, use this charting software. We're very thankful to funders to help bring that to the table. And you're not even going to know you're collecting these quality metrics in the background. But I collect different data than Chrissy does right now on specific things other than what is required by NEMSIS and the federal government. So in this MIH space, everybody's doing something a bit different, and we have to standardize. Again, back to the I'm going to have different and unique challenges than Chrissy or my folks in Casey Mo, taking care of a diabetic high utilizer, but the quality metrics are the same. Their A1C draw is still due at the same time. We have the same goals. We have the same SDOH assessments and tools. And so where I wanted to kind of tie in one of the other questions in the chat about, what tools are you using? The brilliance behind having the CP is we take that Prepare Tool assessment and then we try to fix whatever we can in the moment, and then utilize our CHWs throughout our control center and then our internal network and our friends to close as many gaps as possible in the moment while we're there and sitting in their living room. I'm sure Christy or David have a different take on my level of crazy.
Let's pull the conversation forward to building on there's opportunity for standardization, common data. We can look at this together. We're meeting unique needs, but there's this foundation of data. That sounds like some of the same ingredients for the conversation about reimbursement. So David, I'll turn to you. Thinking about reimbursement, Kansas is a state that community paramedicine MIH is not defined. There's not that reimbursement opportunity. That was a key challenge that came up. We've talked about a lot of the pieces that go into MIH programs, but that's where ultimately a lot of the conversation wants to go. So when we think about reimbursement, you think about some of the policy conversations you've had. What are some of the things we need to explore? What are some of the policy changes that could move us forward towards that sustainable funding opportunity?
No, I think this is a great discussion, and I do think, but just on partnerships, I do want to recognize the Patterson Family Foundation. It's been great to partner with them. They're really helping support the Chrissy's pilots in Missouri and Kansas. And we're partnering to help provide some of the research to go along with evaluating that project so that we can make the case to policymakers. We obviously are very thankful for the great partnerships that we have at KDHE with the Medicaid office. I see that Bobby and others are on the call. I do think we need to make sure that we can demonstrate how community paramedics can save Medicaid money. When you look at community health workers, there's clear data out there that for every dollar invested in a community health worker program, you're saving $2.47 to the state Medicaid program. And I think that's the recognition that Justin and Chrissy and others involved with this demonstration project have, that utilizing community paramedics will have the same return on investment, not just save the state Medicaid program money, but ultimately our larger goal is to improve the health of the Medicaid beneficiaries. And I think we're seeing that. There's strong data out there from places like Maine. The policy approach they took was really to use money within the MCO contracts to finance pilot projects, much like private philanthropy is doing here. You saw ED reductions, cost savings. You see great success from Justin's pilot in terms of delivering primary care. So I think that all of that evidence is helpful. And I think we've been thankful that KDHE and Medicaid have engaged in conversations with us and want to look at some different options. Like community health workers, there's the opportunity to explore state plan amendments where community paramedics could certainly bill for certain codes. I think there's also opportunities to look at CHWs accessing other dollars available through managed care or for MCOs to contract with community paramedics. So I think there's a number of different opportunities. And then, of course, there's an opportunity to ask the legislature for pilot funding, which some states have pursued. And I think getting support from Medicaid is important. And hopefully it's important to make sure that the private payers like Blue Cross Blue Shield also recognize community paramedics, because it can't just be Medicaid that's paying for these services. There's uninsured patients that are in the gap, but there's certainly patients that are covered by commercial payers like Blue Cross Blue Shield that benefit from community paramedicine just like they benefit from paramedic service. So having the partnership with Medicaid will hopefully drive that conversation forward too. And I think they've really helped us recognize we need both set of payers at the table. And I think there's a role for Medicare as well. I'm sure Justin and Chrissy have some more to add.
I mean, I always have something to add, but yes, I mean, we'll go down from the payer standpoint and just things that are happening in our own state. We have a contract with Healthy Blue in one of the MCOs through an ILOS, and have been working with our state Medicaid office, working with others. We have 3 MCOs. We have pilot funding project. First came from United Healthcare, really wanting to explore the model and see what we could do for their patients. But I think that we're the ultimate goal is the federal level, and I know Wyatt will take us there here in a minute, so I'll time out. But I'm a chronic disease patient. I'm a commercial payer. I utilize our own MIH services in my community because I don't want to drive an hour and a half, 2 hours for my infusion every 8 weeks, right? Those resources aren't here. And we have many commercial payers that they need those services because they're not available in the local area, or they have barriers to transportation because they retired from GM. They have great insurance and they don't have a way to get back and forth to their doctor's appointments. And so we're navigating utilization of NEMT, or you want your care rendered in your living room. Which one would you want as a patient? I know what my answer is because I'm using the services.
Justin, I'm going to stay with you, and I just want to pause for a second and say thank you to everyone that's added so many questions in chat, and all the comments and all the great discussion. I think we could continue talking for a couple more hours. Unfortunately, we're coming up on the end of our time. And I want to be respectful of everyone's time. And I want to give everyone one more chance to add something to this discussion. And I hope you all see, everyone that's on the call, you see this as a continuation of conversations you've had, and you feel like you have some new ideas and new conversations to move forward and have with your partners. But I'll come back to you first, Justin. You brought up federal policy. Let's go there. So we've talked a lot about MIH programs and the local considerations, the state policy discussions, but there's potentially a federal angle to this. Briefly share some of that work that I know you've been involved in recently that comes into play here.
So I have the pleasure of serving as the chair for the National EMS Association's Economics Committee, or NAEMT. And for those of you who have been watching, some states have introduced and passed, and Missouri is one of them, treat no transport, where Medicaid will reimburse for if there's a 911 call, an ambulance responds, and they don't need to go to the hospital, they meet criteria. There is a payment behind that. For those that are looking at it, it's coded as A0998. Recently introduced on a bipartisan level in Washington, D.C. was treatment in place legislation. And so really taking it to that federal level of the acknowledgement that was a huge step of saying these are healthcare providers that in conjunction with medical direction, there are patients that can be appropriately cared for at home. I will also argue that we have used in this discussion with the federal government, look at the pandemic waiver data that applied to our business that showed that, one, there was massive dollar savings, but great quality for patients when hospitals were bursting at the seams. And we kept a lot of people at home that historically would have gone to a med-surg unit. And then also ET3 data, if we remember that kind of pre-pandemic, that's recently come out that showed, while it was not applicable to all of our rural areas, where it was applicable and in place, it worked really, really, really well. So we're using those. There's draft legislation that's coming up around MIH startup dollars that is hopefully will be introduced. And then also pushing for formal sustainability and recognition from CMS for community paramedic and MIH work as a whole, so that, again, with that overall umbrella of, we render healthcare every single day. Sometimes we take people to the hospital, but sometimes a crisis stabilization unit is the best place for a behavioral health patient, or sometimes staying in their own home is what's best for them as well. So I mean, that is happening. And if you're not paying attention, you absolutely should be, because this is a game changer.
Thanks, Justin. And as folks know, KHI, we're nonpartisan. We don't advocate for any specific legislation, but it's worth us pointing out, acknowledging there's a federal policy element to this that is ongoing, as Justin shared. We keep coming up on our time, but
Can I
Christy,
just jump in? Oh,
yeah, David, you go first.
well,
Then
I think the big thing is there is a federal policy update like component, and the most important piece right now is for everybody on this call to call your members of the Senate, so Senator Moran and Marshall, and obviously Senator Hawley in Missouri, and tell them to protect Medicaid. Kansas and Missouri both have billions of dollars to lose with the proposal that passed the House. And if the Medicaid funding is cut at these levels, community paramedic programs are going to be devastated. Hospitals are going to be devastated. We have more financially at risk hospitals in Kansas than any other state in the country. People think we're going to be okay because we're a non-expansion state. That's just not true. Depending on the estimates, 13,000 Kansans to 22,000 Kansans are going to lose coverage. And we're going to lose money every year from our state-directed payments, which support hospitals and in some states, EMS services. So we have, I think, $3.3 billion we're projected to lose over the next 10 years. If the current freeze on state-directed payments happen, that's a lot of money to lose for Kansas, given that we haven't expanded Medicaid and we've lost nearly $8 billion by not expanding Medicaid. Missouri has more to lose because they're an expansion state. So they're in the closer to $10 billion, I suspect, over 10 years, maybe more, but you're looking at tens of thousands of people being uninsured. So you can't sustain services like paramedics in hospitals at the level we have now if we don't protect Medicaid. So we are not immune from that. And I just urge you all to, if you want to expand creative services like community paramedicine, we need to protect Medicaid.
And it's Hawley and Schmidt, just to throw the other name in there for David. If you're on the Missouri side, start dialing.
So another wrinkle to this broader conversation that extends to federal policy and can have impacts at the state level. I'm gonna bring us all the way back to the opposite level as our final thought before I turn it back to Rebecca. I know there's more we think more ground we could talk about, more discussion to have. I invite you all to go out and continue those conversations. But Chrissy, I wanna give you the last word. For those that are in a local community, they're in a local organization, they've heard this discussion, they've said, man, there's a lot to think about, but this sounds like something I'm interested in learning more about. What's your recommendation as someone that's in that early stages of exploring this in your own community?
Yeah, I think being open to those conversations and recognizing that it really can happen anywhere. Find those agencies that are already doing it or starting to their pilot programs. I think sometimes when we hear these big terms, as particularly in our rural areas, we think, oh, those are for the big departments, the big paid departments, the urban areas, and we are intimidated to take those on in our smaller agencies. So I encourage you to partner with someone, reach out, ask the questions, continue the conversations, and recognize really truly that can be beneficial both financially and really to your personnel just being fulfilled in what they do. They're wanting to help people, and then the benefit to your patients. So I just encourage you, don't stop now, keep asking questions, be curious, dig in and find information. It's out there. And I know like Justin's a great resource. I'm happy to answer any questions I can. We're just in the very beginnings, but just know that it's really for everybody. Zip code doesn't matter. This can play out in every community in Kansas and in Missouri. It may look a little bit different how the delivery of care takes place, but is beneficial for all of our citizens.
Thank you, Chrissy, and thank you to all the panelists for all your insights, all your feedback, all your wisdom. We're really appreciative at KHI in our role to convene these crucial conversations that can be challenging, that are complex, but ultimately are really meaningful to that shared information or that shared goal that we all have to see healthy, thriving communities. I'm going to turn it back over to Rebecca. Folks, please stay on if you can. Rebecca's got some final notes before we all let you get out of here.
We would like to share that we do have a lot of other resources, again, to support your work or maybe just things that you're curious about or interested in. Next Tuesday, we have the second session of our quarterly KHI policy series, Exploring Medicaid in Kansas. And so Tuesday's session will focus on can care and behavioral health with a deep dive into certified community behavioral health clinics. So if you're interested, please be sure to join us on Tuesday. We also have a newer federal policy product series that's called Hill to the Heartland. It's a federal health policy briefing, and this series has a range of different products that really focus on federal health policy discussions. So be sure to check it out so that you can stay informed on everything that's going on. And lastly, we invite you to explore our recent reports, everything from the annual insurance update. We just had a report come out about Medicaid expansion as well. So feel free to check out our website and also reach out and connect with us. We'd love to hear from you, know what questions you have, and other ways that we can support. Again, thank you for joining us today, and we hope you have a wonderful rest of your afternoon.